Hello everyone, welcome to Patho Excellence. In the last video, we learned how to look at a skin biopsy, a step-by-step microscopy checklist so that nothing important is missed. But once you have looked at everything, the next question is, how do you make sense of what you are seeing? So this is where reaction patterns come in. According to Weedon and Ackerman, the skin has a limited number of ways to react, and when you group your microscopic findings into reaction pattern, spongiotic, psoriasiform, interface, vesiculobullous or granulomatous, the diagnosis automatically becomes focus. So today, this video takes the next logical step after the checklist from observing features to interpreting patterns. So, if the checklist tells you what is present and reaction patterns tell you what it means. Now, let's apply the Weedon Ackerman pattern based approach and make skin biopsy systematic, not confusing. And why should we learn reaction pattern? Because skin has a limited ways of reacting to injury and different diseases can look similar. So, pattern recognition simplifies diagnosis. As we have already discussed in last video, low power diagnosis is the key in dermatopathology. So, this reaction patterns help in narrowing differential diagnosis, logical reporting in exams, and better clinico-pathological correlation. So, reaction pattern basically converts a confusing biopsy into a structured diagnosis. Now, what is reaction pattern? So, it is a reproducible microscopic response of skin to various inflammatory insults. So, it is based on architecture, not individual cells, and identified mainly at the scanner and low power view, and high power is used only for the confirmation. So, we will learn Weedon's and Ackerman's way. First of all, Weedon's scheme. So, this scheme, there are two main different morphologic features. One is tissue reaction pattern, second is the pattern of inflammation. So, these are 6 major reaction patterns, and significant number of these inflammatory dermatoses follow or categorized in a 6 major reaction patterns. So, first is lichenoid, psoriasiform, spongiotic, vesiculobullous, vasculopathic and granulomatous. And pattern of inflammation, there are 4 patterns. One is superficial perivascular inflammation, superficial and deep dermal inflammation, folliculitis, perifolliculitis and panniculitis. Now, there are numerous dermatoses which show superficial perivascular inflammatory infiltrate in dermis and limited number in the other categories. And sometimes this panniculitis and folliculitis are regarded as a major tissue reaction pattern because of their easily recognizable pattern. Now, according to Ackerman's schema, there are this list shows one is superficial perivascular dermatitis, superficial and deep vasculitis, intraepidermal bullous disease, subepidermal bullous disease, nodular and diffuse dermatitis, fibrosing dermatitis, folliculitis and periculitis, and septal and lobular panniculitis. So, here in this figure you can identify these patterns one by one. Superficial perivascular dermatitis means only the superficial dermis shows perivascular, these are the vessels, and perivascular inflammatory cell collection. So, this is a superficial perivascular dermatitis. Here Superficial and deep means superficial dermis as well as deep dermis shows vessels, and dilated vessels are surrounded by inflammatory infiltrate. Vasculitis, here the vessels are not only having perivascular inflammation, but there are some changes in vessel wall also that we will learn in next slides. Now, intraepidermal bullous disorders means here you can identify bulla in the epidermis. Subepidermal bulla means at the junction below the epidermis there is a bulla formation. And here nodular and diffuse dermatitis. Nodule form of collection of inflammatory cells. Here the whole dermis in a diffuse pattern shows inflammation. This is fibrosing dermatitis. Here the dermis show fibrosis. Folliculitis and perifolliculitis means the hair follicles are affected and mainly shows inflammatory infiltrate surrounding the hair follicles. Septal and lobular paniculitis. Paniculitis means subcutaneous tissue where there is lobular pattern as well as septal pattern, where in septal pattern there is diffuse inflammation, and here lobular means surrounding the lobules of the fat there is inflammation. So, this is the Ackerman schema. Now, let us see one by one all 6 patterns of Weedon. First is lichenoid tissue reaction. Lichenoid means it is like a leaf like, or this is algae like skin lesions over the here we can see on the hand, and this is also called interface dermatitis. So, interface dermatitis, it is a prominent cellular and tissue changes at the dermo-epidermal junction. So, interface means at the junction there are primary changes and secondary changes. Primary changes include basal cell vacuolization, apoptosis, where you find colloid bodies and necrotic keratinocytes, and infiltrate at the dermo-epidermal junction, which often obscures this junction. Secondary changes include in epidermis like atrophy and sawtooth appearance, extensive vacuolization, and dermal changes include edema, perivascular infiltrate, and pigment incontinence. Now, this interface dermatitis are of 2 types. One which is interface dermatitis of lichenoid type. So, lichenoid in which there is band-like infiltrate is prominent and lichen planus is the prototype. And second is the vacuolar type, means vacuolization of keratinocytes at the junction of dermo-epidermal, and it is the erythema multiforme and pleva as its prototype. So, you have to remember what are the conditions where you can find lichenoid reaction. First important that you are getting in mostly in your exam is lichen planus. Second is drug induced lichenoid reaction, lichen striatus, benign lichenoid keratosis, some other disease like ashidermatosis, graft versus host disease, lichen nitidus, then Groton's papule, lichenoid reaction in syphilis, HIV and sarcoidosis, and lichenoid reaction in seborrheic keratosis, wart, some nevi and porokeratosis and basal cell epithelioma. So, what is lichenoid reaction? One is basal cell degeneration, superficial mononuclear infiltrate in upper dermis, colloid body and pigment continence. So, only an occasional civet body and very focal vacuolar change is seen. This is a feature of drug reaction, right. So, you may find this type of feature, but only few or focally vacuolar change if you find, then it is a drug reaction. So, microscopically what you will see first is hyperkeratosis. So increased keratinous layer. Second is wedge shape hypergranulosis. So wedge shape means here this is, you can see this is the granular layer, how it is increased. So this is called wedge shaped hypergranulosis. So you can see some area shows normal and some of the area shows this type of increase in the granulosis. So increase or thickened granular layer in the wedge shaped. So this is hyperkeratosis, wedge shaped hypergranulosis. Third is sawtooth appearance, or it is elongation of rete. So epidermis is show this type of sawtooth appearance. So this is sawtooth appearance of or elongation of rete. And basal cell degeneration. So basal cell degeneration is basically here, see this is the basal layer, right? And here you can identify vacuolar degeneration of this basal cell. So this is called basal cell degeneration. And fifth is pigment incontinence. Here the melanocytes are there and you can identify some of the melanin pigment in the upper dermis. So this is called pigment incontinence. And at the junction means this is epidermis and this is the dermis. So at the junction, these are the band-like infiltrate of lymphocytes. So these are the lymphocytes and this is the band-like infiltration of lymphocytes. So this is how you have to remember. Lichen planus show hyperkeratosis, wedge shaped hypergranulosis, basal cell vacuolization, sawtooth of rete, elongation of rete, pigment incontinence and band-like lymphocytic infiltration. So in microscopy, here you can identify, this is called lichenoid interface, where you can find this band-like infiltrate where these are the lymphocytes in the at the junction, and this is sawtooth appearance of rete. So here and here you can identify this is the vacuolar basal layer. So vacuolar change, sawtooth rete, some pink bodies without nucleus. So these are civet bodies. This is band-like lymphocytic infiltration, and because of extensive vacuolar change, there is a cleft between epidermis and dermis. So this cleft is also known as Max Joseph space. So this is lichenoid interface. Now vacuolar interface. In vacuolar interface, at the junction, most of the or all of the basal cell shows vacuolar degeneration. So this is called vacuolar interface. So basically these both patterns are called lichenoid reaction pattern. So here you can identify hyperkeratosis, wedge shaped granule hypergranulosis, some of the having sawtooth appearance, band-like lymphocytic infiltration, and here in this you can identify this is the basal cell vacuolization, right? So this is again, and yes, civet bodies, where you can identify civet bodies having a pink colored appearance here. So these are the civet bodies you can identify. Now, what are the other features in this lichenoid reaction pattern? So, the type of basal damage where vacuolar change is sometimes more prominent than cell death. It is in lupus erythematosus, dermatomyositis, myositis, poikilodermas and drug reaction. And The distribution of accompanying inflammatory cell. So if the infiltrate touches the under surface of the basal layer, which is in the lichen planus and its variant, early lichen sclerus at atrophicus and disseminated superficial actinic porokeratosis. And suppose it obscures the junction. So this is called interface dermatitis, like in the erythema multiforme, paraneoplastic pemphigus, fixed drug eruptions, pleva or graft versus host disease. And it involves the deep as well as superficial part of dermis. Then it is lupus erythematosus, syphilis, photolichenoid eruption and shrub drug reaction. Third is presence of prominent pigment incontinence. So whenever pigment incontinence is along with this lichenoid reaction, you can have in mind like drug reaction, poikilodermas, lichenoid reaction in dark skinned people, and some sun exaggerated lichen planus variants like lichen planus actinicus. You have to see also the presence of satellite cell necrosis like lymphocyte associated apoptosis, which is defined as like two or more lymphocytes in close proximity to severed body. So this is a feature of graft versus host disease reaction. Regressing plain warts, subacute radiation dermatitis, erythema multiforme, and subdrug reaction. So this is how you can identify. This is you can see here. This is apoptotic body or keratinocytes, and these are the lymphocytes accompanied to this, and this is called exocytosis of lymphocytes in epidermis. So this is epidermis, and here you can identify lymphocytes. This is called exocytosis, and this is lymphocytes accompanying a severed body. And basal cell vacuolization and some lymphocytic infiltrations you can identify in the dermis. So this is a section showing graft versus host disease. So lichen planus important points are: one is mild hyperkeratosis, irregular acanthosis, focal or wedge-shaped hypergranulosis, basal cell degeneration, sometimes Max Joseph space, sawtooth appearance of retiridges, colloid bodies, dense band-like mononuclear infiltrate, and pigment incontinence. And this is, if you find all these features, your diagnosis is lichen planus. And if you find parakeratosis, so it almost always rules out lichen planus. So this is a flow chart to differentiate different diseases of lichenoid reaction. So first of all, if you identify interface dermatitis, then look for prominent infiltrate and vacuolization of cells. So whether if it is lichenoid type, then band-like infiltration is present or patchy infiltrate. If band-like, classical band-like infiltration, many retiridges are involved, then it is lichen planus. Parakeratosis is there and 3 to 4 retiridges are affected, then it is lichen striatus. Ball and socket like pattern, 2 retiridges, lichen nitidus. Disc keratosis, lichen planus like keratosis. If eosinophils are present, it is drug induced. Plasma cells, mostly secondary syphilis. Now, lichenoid type means infiltration is there and it is patchy. Then discoid lupus erythematosus if present, then you can see this PAS stain is positive. Pigment incontinence is there, then ashidermatosis. Deep infiltrate pigment incontinence, this is fixed drug reaction. Hemosiderin if present, then lichenoid PPP, and plasma cell if present, secondary syphilis and satellite cell necrosis. If it is there, it is graft versus host disease. Now, vacuolar type interface dermatitis. So, if orthokeratosis and superficial infiltration is there, erythema multiforme. Mixed infiltration, pigment incontinence, fixed drug reaction. Parakeratosis, mild infiltrate, pityriasis lichenoid, chronica, and wedge-shaped or wedge-like infiltration and RBCs in epidermis. So, it is pleva. Now, pigment macules are there and basal cell degeneration is present. So, if it is band-like, lichen planus, patchy, ashidermatosis, mixed and deep infiltrate and occasional eosinophil, it is Frick's drug eruption. And no basal cell degeneration, but still pigment incontinence. So, you have to see whether spongiosis, increased basal and dermal pigmentation, then it is post-inflammatory pigmentation. Now, second pattern. Second pattern is psoriasiform tissue reaction. Psoriasiform. So, what is psoriasis? Psora means itchy, and psoriasis, asis means condition. So, it is itchy condition. So, psoriasiform tissue reaction where you find epidermal hyperplasia and elongation of retiridges, which is here regular in manner. No significant epidermal hyperplasia in the early stage. You can find dilated vessels in the papillary dermis and an overlying suprapapillary scale may be the dominant feature of early lesion of psoriasis. Mitosis are increased in basal keratinocytes in this pattern and particularly seen in the active lesions. So, what are the causes where you can find psoriasiform reaction? So, first prototype is psoriasis vulgaris. Second, lichen simplex chronicus, prurigo nodularis, chronic dermatitis, dermatophytosis, secondary syphilis, sarcoidosis, drug eruption, some cutaneous lymphoma, overlying dermatofibroma, pityriasis rubia, pilaris, seborrheic dermatitis, age-related psoriasiform reaction, erythroderma, and pellagra and acrodermatitis entropathica. Now let's see what are the microscopic features of psoriasis. So here you can find first of all hyperkeratosis. So this is keratin layer increase. So hyperkeratosis. Now focal parakeratosis. So focal means some of the area shows presence of nuclei. So this is area of parakeratosis. This is area of parakeratosis. So presence of nuclei in the keratinous layer. So this is focal parakeratosis and focal hypogranulosis. So here you can see this is the granular layer presence, but here where you find parakeratosis, at that area you cannot see granular layer. So this is hypogranulosis. So alternating area of normal granular layer and hypogranular, and hypogranular layer is present with the area of parakeratosis. Second thing, regular acanthosis. Acanthosis means thickening of epidermal or spinous layer. So regular means you can see this is called test tube like appearance of epidermis. So this is regular because all rete ridges looking similar. So this is regular because having similar length. So this is, you can draw a single line, then it is psoriasis pattern. So it is called test tube like or club shaped elongation of rete ridges. Third thing is dilated and tortuous blood vessels. So these are the blood vessels which are dilated and tortuous. Most in the papillary dermis and in the superficial dermis. So these are features of psoriasis. And this is, here you can identify temporal evolution of lesion. So earliest lesion where you find only the dilated vessels and few inflammatory cells in the perivascular area. Second, initial stage where you find mild parakeratosis. So see, here you can identify nuclei and few neutrophils at the stratum corneum. So this is neutrophil, and some of the here also in epidermis you can find neutrophil. Then stage of parakeratosis with hypogranulosis. So here you can see, here in this stage granular layer was present, but here there is absence of granular layer and parakeratosis along with the presence of nuclei. Now in this you can identify perivascular inflammatory cell infiltrate, tortuous and dilated vessels. Now in established lesion where these rete ridges are elongated, and one is Monroe's microabscess. What is Monroe's microabscess? It is nothing but the collection of polymorphs in the keratinous layer. And last is hypertrophic psoriasis, where thick hyperkeratotic corneal layer along with the parakeratosis and tortuous capillaries loop in the papillary dermis, elongation of rete ridges, absence of granular layer. So it is hypogranulosis. Now, what are the pathognomic features of plaque psoriasis? Already we have discussed focal parakeratosis, focal hypogranulosis, irregular acanthosis with suprapapillary thinning of stratum malpighi, regular even elongation of rete ridges with bulbous thickening, and stratum corneum Monroe microabscesses can be seen. Sometimes accumulation of these inflammatory cells or polymorph in the sponge-like network of degenerated keratinocytes in the stratum granulosum. So it is called Kogos pustule, and irregularly dilated tortuous blood vessels in the dermal papillae and perivascular lymphocytic infiltrate along with the spongiosis. So here these are the plaque psoriasis pathognomic features. Parakeratosis in the some areas, then hypogranulosis where you cannot find any granular layer, elongation of rete ridges, right? So it is bulbous rete ridges. Irregular acanthosis means some area shows very much thickened this malpighi layer here, but here there is thinning of epidermis. So this is called irregular acanthosis. And dilated and tortuous vessels. So here you can identify these are the dilated capillaries. RBCs are present in vessels. So you identify vessels with the help of presence of RBCs in the lumen. So this is thinning of epidermis. Here acanthosis is marked. So this is called irregular acanthosis. Dilated capillaries are there. Here in this you can identify a granular layer here, but there is absence of granular layer. This is parakeratosis and this is a micromunros abscess where you find polymorphs in the stratum corneum. So these are the microscopic features to identify plaque psoriasis. So here this is called micromunro abscess, which is in the keratinous layer, but Kogoj abscess which is present in the epidermis layer. So this is Kogoj pustule, this is micromunro's abscess. Again you can identify this is abscess. Now psoriasiform hyperplasia, we have to identify polymorphs in the epidermis or no polymorphs. So if you identify Munro's abscess, it is psoriasis. Sandwich sign dermatophytosis, in which you identify a corneal layer, in between you can identify this fungal hyphae. Follicular polymorphs in the seborrheic dermatitis. No polymorph like mite in stratum corneum, scabies, spongiosis if present, chronic dermatitis, vertical collagen bundles, lichen simplex, chronicus, vertical parakeratosis, checkerboard pattern, which is pityriasis rubra pilaris, moon-like parakeratosis, it is sporiasis and plasma cells, mainly in the secondary syphilis. Now third pattern, it is the spongiatic reaction pattern. So here in this lesion you can identify some edematous or lesion where in microscopically you can have mostly example is eczematous tissue reaction. So eczema is a spongiotic reaction pattern. It is characterized by spongiotic vesicles, exocytosis of inflammatory cells, parakeratosis, and these changes are spotty or focal, and along with this dilated blood vessels in the upper dermis. So here there is here evolutionary stages, like for early stage there is only a perivascular inflammatory infiltrate, and then there is papillary dermal edema and spongiosis with microvesicle formation. So here, see, this is the normal epidermis. Here you can identify these cells are little bit having enlarged, and you can identify gap in between these two cells. So this is edema in between or intraepidermal edema. This is called spongiosis. And microvesicle formation. See here, this is microvesicle formation. Now as the lesion become old, here there is parakeratosis. Then after that there is changes like epidermal hyperplasia. So hyperplasia begins, cell epidermal thickness is increased, and there is also in the late stage you can identify hyperkeratosis, and most important is vertically oriented fibrotic uh, uh, these cells like fibrosis in the dermal papilla. These are the perivascular inflammatory infiltrate, hypergranulosis, and parakeratosis. So this is spongiotic pattern. So classification includes, one is lymphocytic spongiosis, where lymphocytes are present, or exocytosis of lymphocytes in epidermis. Almost all form of dermatitis are having lymphocytic spongiosis. Second, some fungal infections like dermatophytes and candida, pityriasis rosea, flava, erythema multiforme, insect bite reactions. Eosinophilic spongiosis mainly in the bullous lesion like pemphigus, pemphigoid, herpes gestationis, insect bite reaction, dermatophyte infections, and incontinentia pigmentia. Spongiform pustules, which you find polymorphs like psoriasis, candidiasis, geographic tongue and subcutaneous fungal infection. Malarial spongiosis, where it is seen in acrosyringium like Malaria rubra. Follicular spongiosis in the hair follicle, where eosinophilic pustular folliculitis, seborrheic dermatitis, and follicular eczema. So, how you clinically and histologically correlate dermatitis and its stages, like first acute stage, where only you find vesicle and crust, where spongiosis, dermal edema, and vasodilatation. Subacute, where scale formation change in color. As the scale develops, there is parakeratosis. Then chronic, where thickening of and pigmentation of skin is there. It is called lichenification, where the stratum malpighi is thickened. Now you know what is stratum malpighi. Stratum malpighi, it is the combined stratum corneum as well as stratum basalis thickening. So here again dermal inflammation, here only you can identify in acute stage epidermal inflammatory cells as well as dermal inflammatory cells, perivascular inflammatory cells. Then there is acanthosis and spongiosis. Spongiosis is nothing but the edematous space between the two cells. So this is spongiosis. Then this is parakeratosis, hypoplasia of this epidermis, increase inflammatory cells, and lastly lichen sclerosis, where you can find hyperparakeratosis, acanthosis, and spongiosis is little bit decreased, but vertical orientation of fibrotic or fibrosis is in the papillary dermis. So this is um, urticaria to acute eczema to chronic eczema to lichen sclerosis. So acute to chronic inflammation where epithelial hyperplasia is increasing. So by histological or microscopically, this is how you can identify in HE section. There is a clear gap between these keratinocytes. So this is called intraepidermal edema, where you can find these are the two cells in between. There is a fluid collection and it is called spongiosis. And in the spongiosis, you can find this acanthosis, irregular, right, and dermal edema, where you find this space in the dermis parenchyma, and these are the lymphocytes, increased number of lymphocytes in the dermal as well as in the epidermis. So this is eczema. This is a classical or very good slide showing spongiotic reaction. So this is spongiotic reaction. So all the eczema shows spongiosic reaction pattern. So this is marked spongiosis and marked deep dermal, superficial lymphocytic infiltration, and you can identify some of these vertical orientation of collagen fibers. So features of acute dermatitis, one is spongiosis. Here it is not prominent but parakeratosis. Then exocytosis means lymphocytes are present in between the epidermal layer. Then upper dermal edema. So here also you can identify light eosinophilic appearance, which is dermal edema, vasodilatation, and here you can identify this spongiotic vesicle. Because of edema, there is a gap in the epidermis cells or spinosum, stratum spinosum cell or here, and perivascular mononuclear infiltrate. So these are the lymphocytic infiltrate in upper dermis. In subacute, there is increased amount of parakeratosis, hyperkeratosis, as well as increased amount of inflammatory infiltrate, and you can identify even exocytosis of inflammatory cells in the epidermis and spongiosis, dilated dermal vessels. And in chronic, you can identify marked hyperkeratosis, but spongiosis will be less prominent compared to acute eczema, and here there is acanthosis. So acanthosis is the thickening of epidermis, and there is elongation of retirages, which is prominent in chronic dermatitis. And dermal edema is replaced by fibrotic vertical bands. And because of this prolonged stretching, these elongated fibers are running parallelly in the dermis. So what is the approach? So first of all, determine whether the presence of spongiosis is present or not. Then type, whether epidermal, follicular or acrosyringeal. Third, identify which type of inflammatory cell infiltrate is present, whether lymphocyte, eosinophil or polymorph. Then associated features which gives the some clue so that you can identify diagnosis, which we'll be discussing in next slide. And in all cases of this spongiotic dermatitis, clinical correlation is a must for arriving at proper diagnosis. So this is the summary slide where if irritant contact dermatitis is there, so where you find important clue is necrosis of keratinocytes and neutrophils in epidermis. In allergic contact dermatitis, where you find spotty spongiosis and vesiculation at different horizontal and vertical levels and in ordered pattern. There is exocytosis, psoriasiform hyperplasia in chronic lesion and superficial dermal edema. And in nummular dermatitis, similar to allergic but more disorderly, right? And seborrheic dermatitis, where, as the name suggests, seborrheic, where scale crust is present, spongiosis is localized to follicular ostia. And these are some another clues for different diseases that we are not going in detail. We will discuss when we discuss all the diseases one by one in separate video. Now fourth is vesiculobullous lesion. Here you can identify these are the tense bulla, and some of the area show ruptured bullous area. So important is when the biopsy we are receiving, we must know whether we are getting biopsy from intact bulla or some ruptured bulla area. So because this will give a different types of microscopic features according to the time period of bullous lesion. So it is must to know about bullous area. Now, before we learn bullous lesion reaction, we must know epidermal dermal junction thoroughly, because if you know the dermal epidermal junction where it is broken, you can identify whether it is pemphigoid group or pemphigus group, right? So here these are the keratinocytes where these keratinocytes having desmosomes, and these desmosomes will help to these two cells return in a proper bond. So if this is broken, or if antibodies to this junction is there, then there is a bullous formation which is called intraepidermal. So two keratinocytes are separated because of damage to desmosome, which is pemphigus. And this is a keratinocytes. This is the basal lamina. Now basal lamina is again divided into three parts. One is here, lamina. So this is the basal keratinocytes. This is lamina lucida. This is lamina densa, and this is sublaminar dermis, which is you can identify having some collagen and anchoring fibrils. So basically pemphigoid bullous are due to damage to hemidesmosome, and hemidesmosome if damaged either at the level of lamina lucida, if this junction is break, there are some different disease. If lamina densa is damaged, then another disease categories, and if here this junction is damaged, these are the some another diseases. So here you can identify, see, this is basal keratinocytes where this is keratin intermediate filaments, this is hemidesmosome, this is plasma membrane, these anchoring filaments and anchoring fibrils and collagen, and this is anchoring plaque. So if damage is here like hemidesmosome and the lesions are bullous pemphigoid, pemphigoid gestationasis. If damage is here at the lamina densa and between anchoring filaments, so this is mucous membrane pemphigoid. And if damage is here at the dermis, anchoring fibrils and interstitial collagen, so it is epidermolysis bullosa acquisita, right? So this is important, desmosome, which is in between two keratinocytes, and hemidesmosome between basal keratinocytes and the basement membrane. So basically bullous diseases are whether they are intraepidermal or subepidermal, and whether it is due to viral or some dermatitis. So location of bulla decides whether it is subcorneal, so mostly in the bullous impetigo, malaria cystulina, staphylococcal scarlet skin disease. Intraepidermal, mostly eczematous, viral vesicle, pemphigus, malaria rubra, incontinentia pigmenti, and subepidermal bulla. So subepidermal bulla, mostly bullous pemphigoid, cicatricial pemphigoid, pemphigoid gestationis, dermatitis herpetiformis, linear IgA disease, erythema multiformis, lupus erythematous, bullous lichen planus. So these are the lesion according to the location of bulla. So here you can see subcorneal means below the corneal layer, suprabasal means above the basal layer, but these are both intraepidermal, and this is called subepidermal, where you can identify epidermis and dermis, both are separated. So this is again a separation of layers and the bullous disease according to the location of the presence of bulla. Suppose granular layer, here if you find bullous lesion, these are these diseases. If subcorneal presence of bulla is there, which is mainly due to some candidiasis and impetigo staphylococcus scalded skin syndrome. Spinous layer, where upper and mid dermis are affected with the bullous lesion. So these are these conditions. If basal layer is affected, where you can find bulla, then it is erythema multiforme, some fixed duct reaction, lichen planus. If spinous layer, which is in the lower epidermis, and suprabasal layer, where if bulla is present, then it is benign familial chronic pemphigus, pemphigus vulgaris. If luminal lucidia here, then bullous pemphigoid, and these are all diseases. Suppose basal lamina is affected and sublaminar connective tissue. Here if it is there, then it is bullous dermatosis of hemodialysis, some bullous eruption of SLE, bullous epidermolysis bullosa dystrophica, dermal type of erythema multiforme, and lichen sclerosus atrophicaus. So these are bullous disease in the epidermis and epidermal junction according to the site of bulla. So we have discussed intraepidermal and subepidermal bullous lesions classification according to the level of bulla. Now, what are the antigens adhesion molecule you can find in direct immunofluorescence? So, in intraepidermal bullous lesion, desmoglein 3, desmoglein 1, and intercellular substance antigen target is there, and fishnet pattern of IgG and fishnet pattern of IgA are present in this immunofluorescence. If subepidermal bullous disease, you know hemidesmosome mainly, so hemidesmosomal antigens, epidermal transglutaminase and type 4 collagen, where in direct immunofluorescence there is linear IgG-C3 band at the junction, linear complement C3 at dermo-epidermal junction in herpes gestationis, granular IgA deposits in dermatitis herpetiformis, and linear IgG band in the epidermolysis bullosa acquisita. So intraepidermal bulla, which is pemphigus group, and subepidermal, which is pemphigoid group. So loss of intercellular adhesion. So two cells are separated because of this loss of adhesion, and mostly immunologically if affected, then it is pemphigus vulgaris, pemphigus vegetans, and pemphigus erythematosus. And non-immunologically, it is Hailey-Hailey disease. So here you can see this is the bullous lesion, but here it is ruptured, and this is called suprabasal bulla formation. So here you can identify this is the basal layer, pink cell line is visible. So this is the basal layer is intact, but suprabasal there is a bullous formation. And because of this, there is cleft and acantholytic cells. So these are the cells they are separated from each other. Some of the cells are still adherent to this basal layer. So this is called a tombstone appearance. So this is tombstone appearance. See, this is called tombstone appearance of this basal layer. So this is characteristic feature of pemphigus vulgaris. So here in this, because of desmoglein or desmosome are separated. So this is detachment of two epidermal or spinous keratinocytes, and this is pemphigus vulgaris, but hemidesmosomes are intact. So these are intact, these are damaged. So this is pemphigus vulgaris and this is tombstone appearance. Now in intraepidermal bulla, a basal layer and the lower layer of stratum malpighi, where you find this cleft, tombstone appearance present. There is acantholytic cell or it is called Zank cell in bulla cavity. They are singly scattered cells you can find. Then rounded in shape, these cells may be rounded in shape, which is squamoid or polygonal keratinocytes. Dense eosinophilic cytoplasm, particularly in the periphery, and there is central pycnotic nucleus. And mostly, if it is progressive, lead to dyskeratosis seen in the Darier's disease. And dermis shows few mononuclear cells. So other less commonly identified features are basal layer lined by a single layer of basal cell, which may form villi-like appearance, which is common in Hailey-Hailey disease and Darier's disease. Eosinophilic spongiosis, where presence of eosinophils in between keratinocytes showing these features. So here IgG deposits in fish net pattern. So this is pemphigus vulgaris. Here you can identify this is a fish net pattern where IgG deposition is present. So that's why these cells are separated from each other because of this antibody against this desmosome. So in this flowchart, you can identify if intraepidermal bullas are there, whether it is subcorneal, suprabasal or basal. So subcorneal, if it is there, then it is subcorneal pustular dermatosis where polymorphs are present. If cogos pustule, then it is psoriasis. If culture positive for bacteria, it is bullous impetigo, and acantholysis is there, then it is this is foliaceous and erythematosus. And here if suprabasal is there, so suprabasal bulla if present, it is if associated with spongiosis, it is dermatitis. Then if it is having hyperkeratosis, then it is called epidermolytic hyperkeratosis. If it is present with the ballooning degeneration, it is in the viral blister. And acantholysis if present, one is this psoriasis vulgaris, where you find row of tombstone, Hailey-Hailey disease, where dilapidated brick wall, and Darier's disease, where you find dyskeratosis. So you have to remember this three form: row of tombstone, psoriasis vulgaris, dilapidated brick wall, Hailey-Hailey, and dyskeratosis. Now, subepidermal bullous disease. So subepidermal bullous disease, where there is most common examples are bullous pemphigoid, herpes gestationis, cicatricial pemphigoid, dermatitis herpetiformis, linear IgA bullous disease, and EBA. So this is the classification of subepidermal bullous disease, where there is acellular dermis and having some cellular dermis with the subepidermal bulla. So if acellular dermis is there with the subepidermal bulla, this is Porphyria cutanea tarda, epidermolysis bullosa dystrophica, some friction bulla, etc. If cellular dermis is present, where eosinophils are present, then it is bullous pemphigoid, herpes gestationis, some IgA bullous dermatosis of childhood. If lymphocytes are present, then erythema multiforme, EBA, bullous lupus erythematosus. Now, if polymorphs are present, one is dermatitis herpetiformis and linear IgA bullous disease, mixed inflammatory, EBA, bullous lupus erythematosus or bullous pemphigoid, and mast cells are if present, it is bullous mastocytosis. So here this is subepidermal bulla, where you can identify these are the inflammatory cells here and perivascular mix, mainly polymorph and lymphocytes, and in the late stage there is here you can identify this is re-epithelialization, means some of the epithelial cells are again present, and this is called re-epithelialization. So you may identify it as a intraepidermal bulla. So it is very much important where what the exactly the age of bulla, and from biopsy where it is taken from, whether it is from the early bullous lesion or from the late bullous lesion. So here you can identify epidermis, this dermis, both are separated because of this subepidermal cleft. This is blister, and here eosinophilic rich infiltrate, and here it is perivascular inflammation. So this is bullous pemphigoid. So bullous pemphigoid, here the junction is separated epidermis and dermis, mark edema in the dermis, eosinophils are seen in the superficial dermis, and here you can see these desmosomes are normal. So keratinocytes are adherent to each other normally. But here the problem is at the hemidesmosome level. So junction from basement membrane to keratinocytes are affected, and there is a cleft at the dermo-epidermal junction, or this is called subepidermal bulla, and this is bullous pemphigoid. And in bullous pemphigoid, this is linear IgG band identified by the direct immunofluorescence method. So already we have discussed subepidermal bulla, whether it is cellular or acellular, we have to define according to the presence of cell in the bullous space. And if it is lupus erythematosus, you can identify this type of granular IgG band. Now this important topic is immunofluorescence. We will cover in another video, but you have to remember whether it is epidermis at the junction or dermal vessels, where you find whether IgG, IgA, what is the pattern, fishnet pattern or lupus band pattern, or whether it is IgA, then whether it is C3, IgG or IgA in the junction, and whether you can identify at the dermal in the vessels whether it is IgG or IgA. According to this, you can identify some bullous lesion. Now, fifth is vasculitis. Here you can identify henox-clonline purpura, where these type of uh, lesions, multiple lesions are present due to vasculitis. Now, what is the classification? According to the type of vessel involved as well as type of infiltrate. And leukocytoclastic vasculitis, LCV, also called as necrotizing vasculitis. It is the most well-defined type of vasculitis. Second is lymphocytic vasculitis, and third is granulomatous vasculitis. Now, what are the causes? So, one is hypersensitivity vasculitis, where it is due to some infection, some medicines or drugs, connective tissue diseases, and autoimmune diseases. And henox-clonline purpura, urticarial vasculitis, cryoglobulinemic vasculitis, erythema elevatum, duodenum, and rheumatoid neutrophilic vasculitis, and some septic vasculitis, and PN or polyarteritis nodosa. Now, what is exactly vasculitis? So, what is the defining criteria? So, there is first of all damage to vessel which lead to hyalinization. So, first is hyalinization of vessel wall. Second, infiltration of the vessel wall by the inflammatory cell, which is focal. And third is fibrinoid. Fibrinoid, which is PAS positive stain, special stain, periodic acid skip PAS positive stain, which is present, and this is of fibrin material, IgG and complement, and around the vessels. So, fibrinoid material is present, and then extravasation of RBCs, and there is presence of nuclear dust, which is nothing but the fragmentation and remains of nuclei, which is seen as a dark blue appearance. So, this is the microscopic picture of leucoclastic vasculitis or necrotizing vasculitis. Here you can identify this is a vessel where first of all you can identify abundant amount of inflammatory infiltrate surrounding the vascular space. Second is this pink eosinophilic deposition, or this is necrotic vessel wall. So, this is called fibrinoid necrosis of vessel wall, where in this vessel wall is damaged and some of the polymorphs and lymphocytes are infiltrating into the vessel wall and it obscure the wall lining. Normally you can identify intima, media and externa clearly, but here you can see these are the infiltrate where they are present all over the wall of a vessel, and this is the pink fibrinoid material in the vessel. So, this is pink material where the where wall is damaged. This is called fibrinoid necrosis. So, this is necrotizing vasculitis and extravasation of RBC. So, here it is not visible, but you can identify RBCs are not present in the lumen of the vessel, but they are present in this area haphazardly in between the these dermal spaces. So, lymphocytes, and these are the red orange RBCs which is present outside the vessel lumen. Nuclear dust, these are the nuclear fragmented part, blue in color, and this is nuclear dust. So these are how you can identify vasculitis. So in this vasculitis, whether it is small vessel or capillary venules or large vessel. If it is capillary and papillary dermis is involved, then septic vasculitis if polymorphs, and lymphocytes, then it is PPP, and if venules and capillary, which is papillary and mid-dermis. If polymorphs, then microthrombi septic vasculitis. No thrombi, then leucoclastic vasculitis. If it is lymphocytis and papillary dermis, then it is viral erythema, and reticular dermis if affected, it is leva. This is again a leukocytoclastic vasculitis, which is acute or chronic. According to the polymorph, these are the vascular diseases. If eosinophils, drugs or urticarial, if it is chronic, and if it is localized or generalized, there is different classification. Now, small vessels we have seen. If it is large vessels, arterioles or artery, then polymorph. If it is polyarteritis nodosa, atypical lymphocytes, then lymphogranulomatosis, granulomatous vasculitis, where if necrotizing associated is Wagner's and eosinophils are present, it's Sturge-Strauss syndrome. Now, sixth pattern, that is granulomatous reaction. This granulomatous reaction, you know various types of granuloma. This is tuberculoid, where there is caseation and Langhans, suppurative, where polymorph are present, xanthogranulomatous, where foamy cells are abundant in amount. This is palisading granuloma, foreign body giant cells, foreign body granuloma, and asteroid bodies in the sarcoid granuloma. So here you can identify granuloma annulare, where you can identify this type of degenerative connective tissue which is surrounded by this palisaded epithelioid cell nest. Here you can find some mucin material in between with the help of Alshan-Pass stain, and this is degeneration of connective tissue. And you can identify this palisading appearance of nuclei, and in between some of these collagen degeneration is there in the center, and most common it is in the granuloma annulare, right? So this is a palisaded granuloma. So palisading, if it is ring shape, granuloma annulare, plate like, necrobiosis lipoidica, subcutaneous necrobiosis, it is rheumatoid nodule, and nuclear dust and neutrophils are present, that is palisading granulomatous neutrophilic dermatitis. Now, in necrobiosis lipidica, it is having sandwich or wedding cake like appearance, where there is alternating layers of degenerated or sclerotic. See, these are the sclerotic collagen layers, and this layer containing granulomatous infiltrate. So this is called sandwich pattern. And sarcoidosis. So sarcoidosis, where you can find granuloma which is having epithelioid cells, and these epithelioid cells are having very less amount of lymphocytes. So this is called naked granuloma. So sparse lymphocytic lymphocytes, and there is presence of asteroid body. So this is asteroid body. This is the granuloma, and here the few lymphocytes are present. So this is called a naked granuloma. Now leprosy, it is whether tuberculoid. So you can identify normal epidermis, but inflammatory infiltrate involves this grain zone. So grain zones in between epidermis and dermis, which is at the upper dermis level. Generally it is clear. In another lepromatous leprosy, here it is in tuberculoid, inflammatory infiltrate is present. Third is well-formed granuloma. So multiple well-formed granuloma with which cell? Langhans type of giant cell. And these are oval in shape, present around the appendages and nerves. Thickened nerve twigs are there and lymphocytes, and M. lepra is extremely rare to find. So here, if I were you can identify multiple granuloma with Langhans type of giant cell. Borderline tuberculoid, where you can find normal epidermis. This is the grain zone, which is seen but narrow. Here, granuloma with epithelioid cells are seen, but mostly having foreign body type of giant cells, and number of lymphocytes is less than tuberculoid leprosy, thickened nerve twig, and occasional M. lepra is seen. Now, lepromatous leprosy. So, this is called diffuse histiocytic infiltrate in the leprosy, where you can identify this is epidermis normal, right? But dermis is diffusely infiltrated by this collection of histiocytes. This is a grain zone which is clear in between the epidermis and dermis, and you find macrophages and plasma cells. Many M. leprae or Mycobacterium leprae bacilli are present within the foam cells with globi or cigar-shaped bundles, and these foam cells are called as lepra or Virchow cells, and this foamy appearance is due to fragmented or granular bacilli, nerve twigs which have onion peel appearance, and see, this is the diffuse histiocytic collection. These are the histiocytes, plenty of histiocytes, and these are the lymphocytes. So these are the Virchow cell or lepra cell. White Ferraco stain, this is a special stain where you have to use 5% HCl concentration, where you find lepromatous bacilli. Borderline lepromatous leprosy, where increased circumscription in the granulomatous response, and you can identify patchy or nodular appearance of this collection of these histiocytes, and here there is large number of lymphocytes compared to lepromatous leprosy and having greater association with nerves and appendages. So normal epidermis, here clear grain zone is present. There is occasional epithelioid cells are there. Then you can identify this nerve twig and this perineural and perivascular collection of lymphocytes, and many M. lepra may be found. So here in the borderline leprosy, appendages are surrounded by this epithelioid cells and histiocytes and lymphocytes. There is erector pili muscles. And how you identify this Virchow or foamy cells? See, these are dark nucleus pinpoint are lymphocyte, but these are the cells having pinpoint nuclei, vesicular chromatin. These are the foamy cells, and this is grain zone. See, this is the clear zone in between epidermis and dermis. So this is called grain zone. So epithelioid granulomas, whether it is tubercular or sarcoidal, and whether it is having necrosis or without necrosis, right? If necrosis is present, the infective, it is tuberculosis, and lupus malariasis, which is non-infective. Without necrosis, you can identify in tubercular leprosy and cutaneous tuberculosis in few cases. If it is non-infective, it is foreign body like silicon, zirconium and aluminium, and sometimes like in tattoo formation. Then sarcoidal, no lymphocytic cuff if it is infective in syphilis and fungal granuloma, non-infective which is sarcoidosis and some foreign body epithelium. Macrophage granuloma, where diffuse macrophages are there. So one is lepromatous leprosy, second is leishmaniasis. Mixed cell granuloma, which is infective, which is fungal granuloma, atypical mycobacterial infection or cutaneous leishmaniasis. Non-infective, where foreign body and pyoderma gangrenosum, and xanthogranuloma, where foamy cells are present, where Teuton giant cell is present. This is juxta granulo this and reticulohistio granuloma. So this is how you identify different types of leprosy. Here we have given histological features like grain zone, what is infiltrate, presence of granuloma, giant cell, lymphocyte plasma cells, form cells, nerve and Golgi, globi of bacilli, where different stages having a different appearance. So this is very important table. Now some of another conditions like lupus vulgaris, which is also called as scrofulloderma or cutaneous TB, where you can find caseating granuloma. So this is pink caseation, and these are the multiple granuloma, and there is thinning of epidermis, or sometimes ulceration may be present. Some infectious condition like molluscum contagiosum, which is here there is a invagination of epidermis and having several septa, where it is dividing into lobules, right? So these are the lobules. These are pink eosinophilic inclusion bodies which fills the cells almost completely and replacing the nuclei, and this is molluscum contagiosum. Some is pityriasis versicolor or tinea versicolor, where you can find hyperkeratosis without parakeratosis, few inflammatory cells in the epidermis, and numerous yeast and plump hyphae in the corneal layer. So this is tinea versicolor, where patient comes with these are hypopigmented patches, and this is the GMS stain, where the hyphae are stained with this stain, fungal stain. This is again herpes simplex virus infection, where epidermis and dermis shows presence of plenty of neutrophils, fibrin material. These are the keratinocytes. They are having a giant cell appearance, where chromatin show margination, means chromatin is located at the margin of the nucleus. So dark margin. Then acantholytic balloon cells. So these are the separated or singly scattered large cells, nuclear molding, where nucleus are multiple nuclei are fitting uh, together and they are like having a puzzle like appearance. So this is called nuclear molding. And steel gray nuclei, this is the gray color appearance. So herpes infection shows one is megaly, so cytomegaly, then margination of chromatin, then there is multinucleation, right, and molding. So you have to remember 4M for herpes infection. Now morphia. So here morphia is also known as scleroderma, which is nothing but the thickened collagen bundles are crowded in the dermis and deep dermis. There is loss of appendages, thinning of epidermis, and narrow space in between this collagen bundle, and sometimes subcutaneous fat is also replaced by this collagenization. So this is a chronic inflammatory condition and it is connective tissue disorder where you find squared off edges. So you can identify like square biopsy. When you receive this type of biopsy, squared off biopsy, and you can identify if collagen bundles, then this is the diagnosis is morphia. Now we have seen all 6 reactions, but sometimes we receive biopsy where there is normal appearance skin, no pattern is visible, and it is looking like uh, without any disease, so nothing disease. It is called invisible dermatosis. So these are the list of the lesions where you can't find any reaction pattern. So you must know this also, that sometimes you cannot find anything, then it is called nothing diseases, right? So this is about Weedon's and Ackerman way of reaction patterns and pattern of inflammations. So now you go through your checklist, you make your checklist ready with the help of low power pattern approach and high power cellular details. See all the layers one by one, starting from stratum corneum to dermis and subcutaneous tissue. And remember, in dermatopathology, confidence comes from pattern recognition, not memorization. So if you train your eye to identify the reaction pattern first, the diagnosis becomes logical, limited, and reproducible. So in the exam hall or reporting room, don't rush to names. First of all, identify the pattern, narrow the differential, and then label the disease. So this is Weedon Ackerman way, and once you follow it, skin biopsies stop being confusing. And here this is a list of the disease starting in the inflammatory condition, starting from superficial to panniculitis. These are the some common diseases you can identify in skin biopsy. So thank you, and keep reading the slide, not the diagnosis. And remember, don't hunt for diagnosis at high power. Pattern comes first, diagnosis comes later. Master reaction patterns so that you can master dermatopathology. And yes, knowledge is power, but power is useless unless you use it. So start the microscopy of skin biopsy and daily do at least 1 to 2 skin biopsy slide microscopy so that you can have a confidence to identify pattern, and you can identify easily some of the common diseases like lichen planus, psoriasis, and most important, bullous lesions. So thank you very much. These are my references for skin pattern and skin biopsy interpretation. I hope you will now easily identify your skin microscopy pattern, and you will easily reach to diagnosis.